Metastatic urothelial cancer is still a cancer which is broadly an area of unmet need, particularly for those patients with advanced disease. But remember, even for those patients who have an operation, the relapse rate is extremely high and the outcome of those patients is poor. So I would put this whole group still in the area of unmet need. We sort of have looked at this cisplatin eligible and cisplatin ineligible issue and said the cisplatin ineligible patients are the unmet needs. I don't really see it that way. If you look at the overall survival of those patients, both groups, the median survival is about 14 months. Chemotherapy alone hasn't been associated with long-term durable remissions, but immune therapy, whichever approach you use, and at the moment it looks like maintenance avelumab is the preferential approach, is probably only putting 20% of those patients into a long-term durable remission, 20 to 30%. We haven't got good biomarkers to pick those patients. And then when relapse occurs, we're giving antibody drug conjugates like enfortumab vedotin. But again, I think that drug is being used too late, in my opinion, in the disease pathway. And so the median survival of those patients, although longer than before with standard chemotherapies with a hazard ratio of 0.7, is still less than what we would like, and certainly without too many long-term durable remissions. So I would say at the moment the whole pathway, frontline chemotherapy, maintenance avelumab, second-line antibody drug conjugates, or indeed FGF inhibitors with erdafitinib, still is curing too few patients, and the median survival remains stubborn at below 15 months. How do we address this issue? Well, I think in metastatic disease there are different ways. Number one is we need to develop better drugs and better combinations. The combination of enfortumab vedotin plus pembrolizumab is being tested in a randomized phase 3 study. That looks very promising in my opinion. There's also a study with ipilimumab and nivolumab. We're going to see some data at ESMO 2021 with that neoadjuvant combination showing high levels of activity. I also hope that randomized phase 3 is positive in the biomarker positive population. So those two combinations I think are exciting in metastatic disease. We also showed some data looking at trying to improve the biomarkers. We're struggling with that at the moment, but we are beginning to see circulating tumour DNA, which may be more useful than historical biomarkers that we used, and I hope that's the case. Ultimately, we're going to need to develop new drugs as well, and new targets, but perhaps move these drugs earlier into the disease setting, into that muscle-invasive space where we can cure more patients. We're beginning to see evidence, and there was a positive nivolumab study for disease-free survival. We've also seen some neoadjuvant doublets with activity in the muscle-invasive space. And it's possible that we can cure more patients in that space, so fewer patients end up in that metastatic area where we've struggled so much.